So let us start off this semester by considering some important terms that are going to be essential for you as a nursing student and as a practicing nurse, really for the rest of your careers. So please feel free to follow along and open up the Notes and Questions tab that's located in As You Learn, so that you can follow along with this discussion. So first off, we're going to look at some terms, and probably the most important term to think about really is, what is pharmacology? Pharmacology really is a study about how drugs interact with living systems. And obviously the living system that we're going to focus on is going to be the human body at this point. So the next term that we have to think about is pharmacokinetics, that really looks at what the body does to a drug. And that's really important for us to think about, so that when you swallow a pill, it has to be absorbed to really get into your bloodstream. It has to be distributed to the site that is going to be most impactful. What really is the metabolism that's important for that drug, or the breaking down or the changing of that drug into molecules that the body can use? And then how do we get rid of this drug, and how is it excreted? And then there's pharmacodynamics, and that really is about what the body does to the drug. What is the mechanism of action? What are some effects that we may see? Are there some interactions that we have to be concerned about in terms of foods or drugs, or that may impact the patient? So sometimes there are certain foods or drugs that we can't take whenever we're taking certain medications. And we'll talk about that a little more in depth as we progress through. So moving on then to pharmacogenomics, that really is an important term, because this really looks at the individual's genetic makeup and how we choose medications for those patients, and how the medications may be impacted by their genetics. So for example, there's an entire population of individuals that has a mutation in their gene coding for a certain type of enzyme group that we'll see and we'll hear about a little later, that sometimes these individuals have very little pain relief from coding, because it's the body's unable to metabolize the drug coding to the active form, so that the drug really can't metabolize coding into the active form, being morphine, and actually get appropriate pain control from coding. So with this group of patients, it really doesn't do any good to give them coding, because it's not going to work. It's not going to relieve their pain. And then we end up with people who have ongoing pain that is a struggle. And there's a whole ongoing body of research that's related to ongoing genomics. So some other important terms that we need to consider are indication, contraindication, and action. When we think about using a drug for certain illnesses or disorders, we want to use this drug that has some proven effectiveness or usefulness for that clinical condition. So let's say a patient is having chest pain or angina. We want to use some medication to open up the coronary vessels to try to get some blood flow to the cardiac tissue. So nitroglycerin is a perfect example. It's a very potent vasodilator, so adding this medication to their regimen will open up the coronary vessels to get blood flow to the cardiac tissue, to decrease the amount of deprived cells without oxygen. So to decrease the amount of cells that are deprived from oxygen. So this particularly is important for patients, and you'll learn as we progress through the next few months as during your nursing student careers. So another drug is contraindication, and this is when a drug should not be used in a particular illness or disorder. So sticking with our nitroglycerin example, let's say we have a patient who is also on some erectile dysfunction medication like sildenafil or Cialis, sildenafil or Viagra, that actually works by causing vasodilation for those patients. So adding another vasodilator in addition to nitroglycerin to these patients may cause profound hypotension, and people end up, actually there have been some case reports and some studies that have shown that people who have taken in conjunction of erectile dysfunction medications and nitroglycerin have actually died because of the combination and the profound hypotension. And the next term that we really need to think about is action. What are the chemical changes and what really is the effect that we expect to see on the body with the use of these medications? So carrying through again with our nitroglycerin example, what do we expect to happen if we give a patient who is having chest pain or angina this medication? Well, we expect the vasodilation from the medication will decrease the amount of pain that the patient is experiencing and actually relieve their anginal symptoms. And actually, there's a lot rolled into that and potentially increasing and showing the need for more advanced therapies. But this is really beneficial in the short term to relieve pain for patients. So other terms that we can look at are agonists and antagonists. Agonists are drugs that have some affinity, some chemical affinity to a cell's receptor sites, and by activating those receptor sites, we turn on the specific action of the cell. So when you think about nitroglycerin, our example again, its action, it's binding to the muscular structure of the vessels, its actions by turning on those cells is vasodilating. It's causing those vessels to spread out and open up a bit more so that blood flow then can get to the heart. By contrast, if you have a patient that's taking an antagonist, this is a drug that may have some affinity for the cell's receptor sites, but it's not going to turn on that cell from doing anything, or that receptor from activating that cell from doing anything, and we're not going to get the illicit, or we're not going to elicit the response that we see happen. So antagonist is a drug that's going to actually prevent that vasodilation from nitroglycerin. In looking at the diagram to the right of this, you see the structure that's the far right. We have a drug that has an affinity or an agonist in that once the medication comes and attaches onto the cell, we have a lot of action occurring in the cell. This is a drug that's going to turn on the actions of this cell. Again, in contrast, we have these black blobs here that are preventing this drug molecule from connecting with the cell and actually activating the cell to produce whatever the action should be. And a good example of these medications, again, could be think of narcotics. So if you have morphine, that this drug may be morphine or codeine or any other narcotic that's activating the cell and relieving pain. An additional, or again by contrast, if we have Narcan that may be floating around in the body, is actually utilizing that spot as the antagonist so that morphine cannot get into connection with the cell and actually relieving pain. So using long-term naltrexone or Narcan there's going to be a lot of these cells, these structures floating around in the body, and using any additional coating may cause a lot of problems with relieving adequate pain control. Another example may be if an individual is
overdosed on some narcotic, giving Narcan to the patient will actually bind to those cell structures and the receptor sites so that the narcotic can't continue to bind with the cells, creating the overdose effects of narcotics that we'll talk about later. So Narcan would be the antagonist to the agonist. So Narcan is then the antagonist to the actions of the agonist, which in this case it is morphine. So some other terms then, we think about side effects, adverse reactions, and interactions. So side effects are some additional effects of the drug that we were not necessarily anticipating and is not necessarily the primary purpose of administering the drug. Sometimes these side effects can be desirable or undesirable. Carrying through with our narcotic example, we plan for patient's pain to be controlled with a narcotic. However, narcotics are respiratory depressants. So if we give too much, or if the patient reacts differently to some of those medications, they may have more somnolence, or they may have a decreased respiratory drive, which can cause a whole host of problems. So side effects of medications can definitely cause significant compromise for patients. And adverse reactions, again, are some of those unintended or undesirable responses. Say we are, again, giving narcotics to treat patients' postoperative pain. However, there's significant nausea and vomiting associated with certain narcotics. So we don't anticipate patients to have those problems, but sometimes they happen. And then interactions occurs when there's one drug or some kind of chemical substance in the body, and when we combine those medications for patients, they end up with some significant complications. And keep in mind that both, there are drug-to-drug interactions that we need to be mindful of, but there also are food-drug interactions that potentially can cause some quite profound problems for patients. Another term that's important is toxicity, and this is where there's an adverse drug reaction caused by an excess dosing of the medication. So, however, there really is some toxicity that occurs in some medications, really regardless of what the dosing is. And in some chemotherapeutic agents or anti-cancer drugs really can cause a profound drop in neutrophils, or a decrease in white blood cell count, which is neutropenia, that puts the patient really at significant risk of infection after chemotherapeutic agents are added to their regimen. However, not only is the chemotherapeutic agent treating whatever cancer may be present, some of those other side effects occur because of the toxicity of the medications. Even though, it's really meant to be there to help treat the cancer, it's going to cause this toxicity or destruction of other components of the body, regardless of the medication being therapeutic for that patient. We also talk about the therapeutic index. Now, this is a measure of the margin of safety for a drug. So it's really determined by a ratio, and you're looking at the lethal dose in 50% of the tested population divided by the effective dose in 50% of the tested population. We refer to this ratio as the LD50 divided by the ED50. LD being the lethal dose of 50% divided by the effective dose in the 50%. If you look at the diagram here, you'll see that in the blue area that the therapeutic effect on the patients, and you're looking at the very far right, we see the toxic effect. So what really is the therapeutic index is what's in between these two areas. So when we think about how and why this is important, when we think about a narrow therapeutic index, if there's a more narrow therapeutic index, the more dangerous the patient's potential complication of the drugs may be. So if we go to the next slide, we see that narrow therapeutic index drugs really are very dangerous. But we have to give enough of the medication to achieve its purpose. However, we can't give too much of the drug because that may be toxic to the patient and even lethal. So we have to monitor the drug levels very carefully we're measuring the serum blood or the plasma levels. Sometimes when we're starting medications on a patient, we may be measuring drug levels every day. We may be doing them every other day or 2 or 3 days or every 4 days or every week and so on, just depending upon how frequently the drugs may need to be monitored for their degree of toxicity. And we are monitoring these medications from therapeutic drug monitoring effect. So when we're doing the therapeutic drug monitoring, we're really looking for a specific range. So the peak level then is how much of the concentration of the drug is highest in the blood. So we're going to do blood levels frequently, let's say for a medication called Dilan, that's an anti-seizure drug that potentially could be very toxic for patients if we get too much. So we're looking at then how much concentration of the drug is in the blood. So let's say sometimes for antibiotics, we're going to use peak level for how much of the concentration of the drug is in the highest level of the blood. And then we're looking also for trough levels, which shows us the lowest concentration of the drug in the blood. And these are really important to monitor for therapeuticness. So we want the medication's levels to be between peak and trough. We'll cover more about peak and trough levels as we look into our anti-infectives, because it's really the big area that we use a lot of that monitoring. So for some of those medications that have very narrow therapeutic indices, we're going to see both peak and trough levels being drawn. So when we think about some therapeutic dose monitoring, there are a few examples here for which we do some therapeutic dose monitoring. I want you to also think about, let's say, a drug called acetaminophen or Tylenol. If you've never really had to go in and have your medication drug levels drawn for Tylenol, it doesn't have a very narrow therapeutic index, and you've never had to go get those levels drawn. However, if you've taken way too much of Tylenol, it can cause significant liver damage or even liver death. But, we really don't have to follow that very closely because it's not really, that dangerous unless we overdose on those medications because it has a very wide therapeutic index. But these medications here have narrow therapeutic indices, so we have to be careful about how much those medications are being taken. Some more terms are non-prescription drugs, and these are medications that could be taken or purchased from over the counter without a prescription. If you look in Chapter 3, you'll see a list of medications and some more descriptions about over-the-counter medications. But we also have prescription medications that are drugs that require a prescription for those drugs to be dispensed from a pharmacy, and those are designated with an RX on the label. So now we need to understand the difference between the terms of generic and trade name. So actually there are 3 names for some particular medication. There's the chemical name that's simply describe what the chemical formula is for the medication. There's the trade name or the proprietary name that's given by whatever manufacturer produces the medication. So you can see Tylenol as multiple different names, depending upon which manufacturer is making those drugs. And then there's the generic name that is then non-proprietary. And an example for Tylenol is going to be acetaminophen. And Motrin would be ibuprofen. And you can see that all the different names and medications here are going to be a little different. So wherever you go and when you're looking at for medications, acetaminophen is always going to be understood as to where, depends on where you go, the medication is always going to be called acetaminophen. There may be multiple trade names because there are multiple manufacturers of acetaminophen, but it's going to be a variety. So that really leads us to think about, should we use the generic name or the trade name? So let's look at the column that talks about our trade names, which there can be some pretty large problems. The single drug can have multiple trade names. It could be confusing for patients and for healthcare providers as well. So in the United States, and we have drugs in and then drugs outside the United States, but there could be all different active ingredients depending upon the different trade names that are utilized for development. And then products with the same trade name may have different active ingredients. When you think about an example of kaopectate, so something happened in the manufacturing of kaopectate in 2003. So first off, you have to think about what really is kaopectate used for, what's its indication. But then also look at what happened from your textbook in 2003, and then think about what ingredient does kaopectate have in it that would pose a significant risk for patients who should not take salicylates in conjunction. So look at your textbook and read that section, and you'll start thinking about why a trade name can be fairly confusing for some of those patients. So take a minute and look at your textbook and think about how to answer those questions in your notes section paper here. So when you think about generic name of a drug, so it's true that the generic name tends to be longer and a little more complicated than the trade name. So the generic name is pretty general in what the understanding of the medication is. When we talk about generic names, there's a tip that's important, that looking at the last few letters that often will give you an understanding of the group of medications that the particular medication may be and what group it belongs to. So amoxicillin is an example. The CILLIN, the cillin component, sounds like penicillin. So think about that amoxicillin then belongs to the penicillin class of antibiotics. So should you use the generic or the trade name? So if you're writing or providing oral communication about medications, talking to your healthcare team, or you're teaching about medications, you want to use the generic name. That's something that we all have a very sound understanding of. So, but if you're using labeling some medications that's where we're storing medications, so be certain that you really highlight the generic name as using for understanding. So it is actually safer to use the generic name because we really don't have a confusionness to the component there. So the other component you have to think about is generic products versus brand named products. So are these medications the same? So again, go to your textbook, and the hard copy is in 21. That should be very similar, very close in the digital copy, but go read that page and look at the difference between generic products and brand name products and their therapeutic equivalents. So is there a difference between the brand name and the generic name, and how does that justify the degree of generic products and names? So would a difference between brand name and generic products justify the use of brand names? So a hint for you for the second question is, it depends. That's kind of a broad statement, but it really does kind of depend on the situation, whether you use brand name or generic names for the product. So look in the book and read a bit more about that and answer the question on your notes and pages section. So we're almost to the end. So thinking about an orphan drug, this is a medication that has a potential use in only really a small number of people, but it's really important enough that the FDA has provided some type of incentive for the researcher to develop and market the medication for those medications, period. So some of the medications, like for example, there are some certain medications that treat Lou Gehrig's disease or ALS. When you think about the general population, those with ALS really are going to be the only group that's going to be impacted by these medications. But the drug is so important that it is life-changing for those medications. So for the development and the research and the marketing for those medications, so the FDA gives certain tax breaks to those companies to continue on with the work of producing certain drugs that may be very effective for a very small population of patients. That is actually very life-changing for those patients. So this is an example that I was describing to you here. Another interesting term that we have to think about is chronotherapeutics, which is when we're giving medications to patients in varying amounts across the whole day period. And it really has everything to do with the patterns or the risks of the disease, or when the symptoms occur or exacerbations. So a good example would be Nexium, which is a histamine 2 antagonist that helps to decrease gastroesophageal reflux disease, or GERD. It helps to decrease the amount of acid production, and it is best given at bedtime. Why do you think that is? It really has everything to do with chronotherapeutics for these patients. At nighttime, most stomach acid is secreted. So most stomach acid is secreted in the evenings. So adding a medication in the evening that treats that condition is most therapeutic. When is the best time for the drug to have its maximum therapeutic effect? So further moving on, we start talking about controlled substances. And these are drugs that can lead to some type of drug abuse or dependence. And these are drugs that are controlled by the federal, state, and local government from laws. And these are drugs that are covered by legislation of the Controlled Substance Act. That's called Title II of the Comprehensive Drug Abuse Prevention and Control Act. So when we think about controlled substances, these are medications that are placed in various different categories, up to 5 categories. So in some states there actually are 6 categories, but Schedule 1 drugs, you can see that these are medications that are LSD or heroin, or medications that have really no accepted use at all for any kind of medical condition at all. There's a very high risk of abuse for these medications. If we further look at Schedule 2, these are medications that have accepted indications, but still have a high potential for abuse. So when you look at dextroamphetamines and dextromethorphan, hydrocodone, oxycodone. So Schedule 3 is the next category, which shows that the risk of abuse is not as high. So we have medications like buprenorphine or naloxone, or really even testosterone, things that can potentially increase potential issues for patients. So then you have Schedule 4s, that these are accepted medical use with low potential for abuse. And then you can read those medications, and then Schedule 5 drugs have an even lower risk of potential for abuse, but they still are used for medical purposes. Use certain things like atropine and codeine or promethazine or phenergan. And you'll notice that based on the blurb at the bottom, that North Carolina classifies marijuana as Schedule 6 drugs that have no accepted medical use. There's low abuse potential, and abuse may lead to limited dependence. Now that's at this time in North Carolina. We know that multiple states are legalizing marijuana and using marijuana as having medical indications, but currently in North Carolina, we are still including those marijuana as a Scheduled 6 medication. So it's important for you to understand the differences between Schedule 2, 3, etc., those medications. There'll be some questions, and I want you to really pay attention on this and look at it carefully, because as you're continuing in your nursing career, you're really going to be impacted by a lot of these medications. So the next thing that we're going to think about briefly is looking at some of the drug legislation over the course of a number of years. When you think about it, it really is interesting when, additionally, when you read your textbook, that relatively speaking, there's not been a whole lot of oversight from the government on drugs. There's been a few more so in the past couple of decades compared to the number of years that medications have been around in the United States. But relatively, when you look over the great span of time, there's not been really that much implication for control or used for control. So what I'd like for you to do is match the correct landmark legislation for its particular purpose. So when you look at the Food, Drug, and Cosmetic Act of 1938, what was its objective? What did it achieve? So I know that's a long time ago, but whenever you think about what that really applies to today in current practice, it's important to consider about. So what does it really mean whenever all those acts of legislation then dealt with how we're going to impact our patient care? So looking at Chapter 3 and looking at drug regulation and development of the process for medications, and see if you can match some of these laws and regulations to their purposes. Also, take some time to think about what the significance of the 2007 FDA Amendment Act is, and what did the Harris-Kefauver Amendment do in 1962? What was its accomplishment? So we now are going to turn ourselves to talking about the nurse's role in drug therapy. These are the 6 rights of drug administration. So do we have the right drug being administered to the right patient, the right dose, the right route, the right time, and is there appropriate right documentation for this medication. So many years, nurses have focused on the first 5, but adding the right documentation has really been important for the last several years, so that we make sure, well, for many years really, that we make sure that we are including every bit of information about that medication in the documentation system, so that everyone who is in that patient's chart is able to see the medications that have been administered. These are going to be components of drug therapy that you are going to have to commit to memory. Really focus on these and commit those to memory. So really the things that you're going to do is tailor the drug prescription and information to the individual. So why are you giving this medication to this patient? And really the ultimate goal that you're going to have to focus on is, what is the therapeutic objective for this patient, and is the drug doing its job, or has it achieved its job? Has the therapeutic objective been met for these patients? And then the thing that I'm really highlighting here with this third point is if you don't know about the drug, if you're not familiar with it, if you're not you're not familiar with its usages, you have to look it up. If you can't find it, you have to call the pharmacy. You have to find out about the drug before you administer the drug to the patient. You never give medications to the patients before you know what they are. And you really can never know too much about any of these medications. So this is really an important slide set that I've given you a lot of important terms to think about. Start now trying to get these under your belt and understand them, because we are going to use them daily. You're going to have a strong grasp in understanding these medications, any of the medications, and how important those are for administrating these medications to patients. So I'll see you in class, and I look forward to learning with you all. And please make sure that you reach out to me if you have questions or comments or need some more clarifications. Thanks.